A very good morning to all of you. So the today's tutorial is on instrumental delivery. So in instrumental delivery, you have two instruments which can be used in obstetrics to assist the second stage of labor, right? So one is obstetric forceps and the other one is ventouse or Malmstrom cup. It used to be, now it is a plastic cup. So this is ventouse and this is an obstetric forceps. Now let's see one by one what they are, right? So let us revise first of all what are the stages of labor. So the first stage of labor is from the onset of true labor pains to full dilatation of labor, cervix. Second stage is when there is full dilatation of cervix and the fetus is expelled. Third stage of labor is when the placenta is expelled. Now, in second stage of labor, when there is an emergency, that emergency could be maternal or fetal, then you need to use an instrument to hasten or to fasten or you make it quick the second stage of labor. So that for that you require instrumental delivery. Now, since we have these two instruments, separate instruments, there has to be or there are two different prerequisites, two different indications in which these two instruments are used, right? Now what are the indications of instrumental delivery? Indications are, as I said, you have to be quick in certain situations for mother or for fetus. For mother, it's going to be maternal exhaustion. She's completely exhausted in second stage of labor and not able to bear down, or you don't want her, or as a her medical condition doesn't permit her to bear down. Like patient is a severe anemia patient, patient is a heart disease patient, severe preeclampsia patient, right? So in these situations, we don't want the mother to bear down, and you want to assist her in the second stage of labor. Now, these are few of the maternal indications. Now, coming to fetal indication, that means the fetus is giving you hint that you quickly deliver me out, otherwise, it is getting suffocated inside. So, what are those situations? It is called as fetal distress, is a vague term, but whenever you have fetal heart rate abnormalities, the other day we learned about CTG monitoring, in which if you see late decelerations, that means the contraction has weaned off, but still the bradycardia is persistent. In that case, you will have to quickly deliver this baby out, otherwise the baby will succumb inside. So for that, you require either a forceps or a ventouse. Now let's see first ventouse. Ventouse is nothing but it is suction cup device which is applied on the fetal head so that you have a grip on the fetal scalp, and then the scalp gets sucked inside this cup by negative pressure which is applied here. Negative pressure is nothing but suction which is applied here, and then the scalp gets sucked inside. Only the scalp and the tissue, it gets edematous and gets stuck inside. So you have a grip on fetal scalp, and then you can give traction and remove it out. Right now, initially when this device was developed, it was a metallic cup. Right, so it was called as Malmstrom's metallic Ventouse vacuum cup. To that, so there was a metallic cup, and then there was a chain. This chain used to go through it, and this chain used to be attached to this handle. And then there was a adapter for to which we used to apply the suction tubing. Right now, with the advent of technology, what they made is this elastic cup or a pliable cup. The metallic cup is rigid; you cannot hold it like this. So you make to make it less traumatic, they made this plastic cup, which can be reused or which can be used easily by the obstetrician, and then this can be applied to the fetal head. Now the principle of the entire ventouse is one is negative pressure, which is applied, which is connected to this ventouse cup, which gets transmitted to fetal head. If this is the occiput, you are going to put it like here, right? So here it is going to be applied. So what happens is the scalp gets edematous. Now that scalp which artificially gets edematous because of the negative pressure which is applied here, that gets sucked inside, and this remains there. This cup remains there, and then you are going to give traction. So that negative pressure the negative pressure and the edema which is produced inside this cup over here is called as, the edema of the scalp is called as chignon, or just the bun which the Chinese women used to have. So it looks like that. So this is the scalp edema which is developed here near the occiput, is called as chignon, right? So how much pressure do you apply? You apply around, you can apply two types of suction machines. One is that centrally which you have in hospitals that can be applied here, or you can apply a ground machine in which you have those two bottles. So the pressure is, the tubing is applied here for the negative pressure. Now this can be developed by two methods, a rapid method and a slow method. So what do you mean by slow method? So you slowly every 1 minute, 2 minutes, go on increasing the pressure. But then you lose almost 15 to 20 minutes to develop that much negative pressure. And then you reach the ultimate maximum pressure which is required is around 500 to 600 millimeters of mercury. That can be done slowly over a period of 15 to 20 minutes, or you can just rapidly connect it to central suction and you can develop it in the next 2 to 3 minutes. But logically, if you see, the second method looks good, isn't it? Because you don't have that much time. You're going to use these instrumental deliveries for what? Basically quick delivery. So you want the things to happen very quickly. So if you're going to lose 15 to 20 minutes only in developing this chignon, you have lost a valuable time. So what we follow these days is, in the recent times, is we apply to the rapid method, and so we quickly raise the suction level to 500 to 600 millimeters of mercury. So this is how the whole principle of Ventouse is there. So once that chignon develops, you are going to hold like this, and this is the handle which is used to hold. Your right hand is going to be applied here, and you are going to get traction, right? So now what are the prerequisites, or we learned the indications, they are almost same for Ventouse or Forceps. So what are the prerequisites? One of the most important prerequisites is the patient has to be in active second stage of labor. There has to be good uterine contraction. The cervix has to be fully dilated. When we were postgraduates, we were taught that even at 7-8 centimeters dilatation of cervix, we can use this Ventouse. But these things are not followed in modern obstetrics. The cervix is fully dilated. For Ventouse, the head can be at zero station. That means if this is the entire pelvis, you know, and if this is the vulval outlet and this is the pelvic brim, the head has to be midway here at the level of ischial spines, right? That is here somewhere. So station zero, it is called as. So at station zero and below 1 plus or 2 plus, that is how we describe it as the head goes down. So for Ventouse, the head has to be at least at zero station. Zero station means practically it is in midway in vagina. It is not come down significantly low down, right? So Ventouse, when we learn eventually forceps, you'll realize that when for forceps the head has to be significantly low down. But for Ventouse, you can apply it even at the zero station, right? But cervix has to be fully dilated. Now coming to the membranes have to be ruptured. If they are not ruptured, there should not be any cephalopelvic disproportion. That means what? There should not be any contraindication for vaginal delivery, right? Then there should not be. It has to be a cephalic presentation, and preferably occiput should be the presenting part, isn't it? You cannot apply it to the face, right? So it has to be a vertex presentation, and you must apply it to the scalp, that is the occipital area, right? So this is how the prerequisites are there for, they are assessed for Ventouse delivery, right? Then coming to how do you apply it? So how do you apply it? Once you have selected the case, the prerequisites are checked. The bladder of the mother should be empty because it is going to obstruct the progress of labor. It is going to occupy the space in pelvis. So urinary bladder should be emptied. Most of the patients we give enema so that even the rectum is empty. So all normal labor patients generally are given enema or the bowel is empty so that such things are anticipated beforehand, and then that bowel is also kept, the rectum is also kept empty. So once you have selected the case, you are going to lubricate this cup with some lubricant. Then with left hand, you are going to separate the labia and you are going to hold the cup like this in a folded fashion. You are going to put it inside the introitus. By separating the labia, you are going to put it inside, and then you are going to reach the scalp and apply it on the fetal scalp like this. tightly on the fetal scalp. Once I apply this, I must check that I have not included any maternal tissue in the cup. That means what? The vaginal wall, if at all there is any cervical rim, it should not get caught between the fetal scalp and the ventouse. So all the rim has to be checked once you have applied it to the fetal head. So once you are sure that you have applied it properly, you're going to make sure that it is more towards the occiput. Means what? If this is the head, this is the occiput, right? This is the occiput, just imagine, and this is the sinciput, right? And you're putting the ventouse here, right? If I apply it here near the sinciput, right, it is going to extend the head. If I pull it down, it is going to extend the head. You don't want extension to happen. You want more and more flexion to happen. So you're going to apply it towards the occiput. So this point is called as pivot point, right, or the flexion point. It is 3 centimeters anterior to the occiput of the fetal head. So you're going to apply. So you try to keep your cup as near the lambdoid suture as possible. So an expert would always do that. And once all these things are checked, there is no maternal tissue coming inside, you're going to apply the negative pressure here, right? So assistant will start applying the tubing here, and it is connected to central suction or the suction machine. Now, once in next 2 to 3 minutes, you are going to reach that 500 to 600 millimeters of mercury negative pressure. Then by that time, the chignon has already developed here. So once that whole thing is checked, in the next contraction, when the next contraction is coming, if mother is able to bear down, you tell the mother to bear down, or you don't want the mother to bear down, then you are going to take the entire effort. And then with those maternal bearing down efforts, you are going to start pulling the fetal head down. So this hand is always kept. So left hand is going to be on the cup, the right hand is going to pull the baby out. So this direction of traction is always downwards first, so that it comes below the symphysis. As I said, it is midway, it has not reached the outlet. So you have to first get it towards the outlet, follow the curve of Caris of pelvis. So get it to the pelvis, to the uh, outlet, so downwards and backwards. Then you are going to pull, once it is almost at the vulva, you are going to pull it forwards. And once it is outside the vulva, while it comes out of the vulva, you are going to make the direction like this. So the direction of pull is downwards, backwards, then forwards, and then upwards and forwards. Right? This is how you are going to deliver the baby. Once the baby is delivered out, you can press this, or you can just straight away disconnect the suction tubing, and the suction will go out. And then automatically this cup comes out of it gets detached from the fetal head. Right? So this is how you deliver in ventouse, when you apply ventouse for instrumental delivery. Now let's come to forceps. Now this is a typical obstetric forcep. So obstetric forcep is always a paired instrument, right? This is how it looks. So each pair of the instrument consists of a blade which is fenestrated, the shank, that is the longitudinal area between the handle and the blade. So this is a shank, right? It gives length to the instrument. Then this is the lock. As you can see, two blades lock with each other at this point, and this is the handle, right? So now this is how the forceps are locked, right? So now see the direction, right? Just imagine the woman is in lithotomy position here, like this, right? I'm going to deliver her like this, right? So what happens? If woman is in lithotomy position, here is the vulval outlet, right? So these forceps are going to go like this in the woman's pelvis, right? So this curve, which you can see, this curve, which you can see on the blade, is called as pelvic curve, right? So if I singularly show this instrument to you, or if I keep this instrument on table like this, what you see is this is the pelvic curve, right? And the curve which is like this, like a cup, so this is the cephalic curve, and the one which is going up like this is the pelvic curve. So this is the pelvic curve, and the internal curve which is going to fit on the fetal head is going to be, so this is how the cephalic curve is, and the one which is going in this direction, this is the pelvic curve of the forceps, right? So these are the two curves which are given to the instrument. Now, what are the indications again for when forceps delivery? Same as Ventouse, maternal and fetal. There is some emergency to help the mother to deliver, and you don't want mother to bear down, or there is fetal indication, and most of the time it is the late decelerations which happen in the second stage of labor. These are applied for preterm feti also to avoid sudden decompression of fetal head, so that there is no intraventricular hemorrhage in preterm feti. So this is applied prophylactically in certain indications of fetus. One is preterm fetus; it's called as cage forceps. It is then there is breech insect after coming head of the breech. So this is how there are indications for forceps delivery. Now, once you have indication in front of you that you need to apply forceps, now what are the prerequisites or how different it is from the ventouse delivery, right? For forceps delivery in modern obstetrics, there is only outlet forceps or very low forceps which is applied, or low forceps which is applied. Now, what is this outlet and low forceps? Now, forceps, if you see the entire pelvis from the pelvic brim to the outlet or at the vulval outlet, it's almost a 10 centimeter area, isn't it? So, there are different levels at which forceps can be applied. So if the head is at brim, almost floating head, then you have to have a long forceps which are not used in modern obstetrics. So what you have for high level, that is almost at the level of brim. So if you deliver a baby from the brim level out with forceps, then that type of forceps is called as high forceps. This is a kind of classification of forceps. Then second forceps is a mid forceps. So when its station is 0, right, that is at the level of ischial spines, midway in the vagina. So when you apply forceps there, that is called as a mid forceps, mid cavity forceps. But in modern obstetrics, again, we don't apply that kind of forceps for high and mid cavity indications, which were used say 50, 60 years back. Now what we do is cesarean section. So even if the patient is fully dilated, but if the head is at 0 station and the head has not rotated, and then the head is floating, in such situations, no instrumental delivery is done in modern obstetrics. So what we do is cesarean section. Now, what are the indications specifically for forceps? So the head is almost at +2, +3, +4. That means almost at the perineum. That means what? The head is coming on the perineum and it is not coming out. There is bradycardia, mother is not able to bear down. So these are the situations when you want to quickly deliver the baby out, or you want to help out the mother to deliver that baby out. So there is, what are the prerequisites again for forceps? So forceps is always applied at a little lower level of the station than the ventouse. So ventouse can be applied at 0 also. Definitely at 0, lower levels ventouse can be applied because it is easier to apply, right? But you cannot apply in modern obstetrics forceps or instrumental delivery or by this instrument at 0 station. So what you do is, let me just put the internet for you.